Okay, I hope everyone can see my presentation. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon to my fellow esteemed colleagues and friends, wherever you may be dialing from. I think it is with great pleasure today I speak to all of you on a topic I feel very passionate about and I'm very keen to share with you about. So this will be lessons from COVID-19 in Brunei Darussalam, which is in relation to public health surveillance. This talk will talk about Brunei's experience with the COVID-19 pandemic and how it has shaped us for the future. So going back in time, our first wave in Brunei started around March 2020. That is when we started to implement response measures. COVID-19 initially was contained through a test, trace, and isolate approach, with the introduction of moderate non-pharmacological interventions and some travel restrictions. With these NPIs, they were implemented in quite rapid succession, and they were implemented early, giving us notable success in reducing the reproduction number early in the first wave. So just some examples of what these NPIs are like school closures, mass gathering prohibition, cinemas and museums were closed, and the prohibition of dine-ins. And you would have travel restrictions alongside them, which are initially travel ban from the EU. And then following that, we would have outbound travel bans for residents, and subsequently quarantine as being made mandatory for anyone entering Brunei. And you can see towards the graph that with these NPIs being implemented and how it affects our reproduction number, by the middle of March, the R has gone down under 1. And all of this is indicative that all these actions has had a positive effect for Brunei. Now, let's have a look at a wider perspective. The pandemic as a whole in Brunei. I think if my fellow Bruneians remember, we had a long period where life in Brunei was quite relatively normal, while other countries outside were still grappling with the pandemic. And that was after the first wave. The first wave had the highest case count of 14 cases. Then we have a long few months where there was no cases from Brunei, only imported ones. But at this time, our vaccination program was in the making and underway. We know it was only a matter of time before COVID comes to our shores. But this is exactly what we needed, time. Time to vaccinate our population. And not long after that, our relative calm was broken sometime in August 21, when we had our second wave, with the highest daily count of 500 cases. And we thought that was hard. Especially when only less than 50% of our population was vaccinated at that time. We still needed more time, but that's all we had. So we had to implement significant restrictions to control the Delta wave. And as I said, we thought we had it hard in the second wave, and came the third wave, which was significantly much more strainful for us, on our healthcare systems, of almost 5,000 cases. And despite having high vaccination rates at that point in time in the third wave, it has significantly stressed our healthcare system. At that point, contact tracing was no longer feasible. Testing, lab capacities were on the verge of being overwhelmed, and a large number of patients were presenting with minor illnesses. And you can see from this graph that the caseload varies in different waves, but the load on healthcare is undoubtedly significant wherever you may look at. Now, what did we do? This is a challenge, and we have to rise to the challenge. So what we do is we implement these quarantine measures for positive cases, and their close contact on a population level will cause significant strains on our health system, definitely. So, especially if you see the variability of the waves for the past 2 years, some are definitely easier to manage than others. the way forward was the rapid adoption of technological advances. That was key to staying afloat during the crisis. That was the way forward. So Brunei has tackled this problem with the introduction of newer models in BruHealth, with the introduction of BruHealth, which is our front-facing application, and its associated digital pandemic management systems on the back end for all the clinicians, all the healthcare workers. So with these two platforms, generally, Brunei has managed to implement and socialize with relative ease its health policies with regards to COVID-19. Also, by doing this, we are able to free up our manpower. Brunei is not a big country. We have limited health local workforce. We have limited health service facilities, just like any other country in the world. So by freeing up those people and letting them do tasks that requires a human input, while automatizing the things that can be automatized, has significantly helped our cause. Now, I'm sure my Bruneian colleagues have heard about BruHealth before. I think the counterparts of it in Indonesia would be Peduli Lindungi, and Malaysia would be My Sejahtera. It's a public-facing mobile application developed to provide a virtual platform to control the spread of COVID-19. It's initially focused for contact tracing, but then additional features were made available for personal health codes, quarantine orders, and also to automatize the triage for COVID-19 patients. So we can decide who can be isolated at home and recover at home, and who would be the ones that would need the input from hospitals. Now, I'm just sharing with you an overview, just quickly going through this, because I know there's a lot going on in this slide, but this is an overview of how BruHealth works. We use BruHealth by integrating our current existing digital health architecture, which is BruHIMS. BruHIMS is our electronic medical record. It has all the data from primary healthcare, secondary healthcare, and tertiary healthcare. That covers around 99% of the population. But not only that, we don't only draw from BruHIMS, we also draw from other areas, such as immigration and national registration. And these information data sets were amalgamated into what we see in BruHealth, so that our clinician interface, our BruHealth public interface, and our admin and policy can see the bigger picture. So BruHealth is the front-facing bit. We also have the back-end bit, which is called the Digital Pandemic Management System. And it is a backstage system for healthcare workers. For the digital workstation, we incorporate the BruHIMS, patient's location, and also social demographic information of all the cases and contacts in Brunei. So this is what has assisted us in contact tracing, isolation, and monitoring for both their cases and their contacts in Brunei Darussalam. By the end of February 2020, the Digital Pandemic Management System has still three main tasks: the digital contact tracing, the automatic triage, and the quarantine and management of contacts. Not only that, we also managed to do some field testing about this on the Digital Pandemic Management System. We've checked the usability and usefulness of the DPMS system for all the three teams, which is the contact tracing team, the quarantine, and the triage team. And if we were to score a few domains question on usability and usefulness, which is how easy it is to use a certain system, and how meaningful and does it get you to where you're trying to do, which is usefulness, and score it on a Likert scale of 1 to 5, we were quite surprised that majority of our respondents rank the Digital Pandemic Management System positively. And this was reproduced across all three areas of contact tracing, quarantine, and triage. And this suggests that it has meaningful and potential use for epidemic control. And consistent with other studies as well, the domains of usability and usefulness were strongly correlated to one another. Now, success during COVID-19. We had critical success during COVID-19 with the use of the Digital Pandemic Management System and BruHealth. there was a strong drive towards the adoption of digital management for diseases by the agencies and population. And as I said, this adoption has considerably offset the large demand on our healthcare system. Overall, the use of digital tech was largely a success. And we began thinking to ourselves and asking ourselves that whether we can extrapolate this success during the COVID-19 pandemic into other future emerging disease, and even the diseases that we are still interested at the moment. Now, the two main things or things that we want to talk about is building on COVID-19 success for disease X. And we want to talk about life after COVID-19. And we can draw on its success in two areas, which is surveillance and response. Surveillance-wise, the questions we ask ourselves is how do we better capture the current communicable disease surveillance data so we have a more efficient and effective alert and warning system. So this is basically to improve what we currently have and to make it easier for our team at the back end. So surveillance for diseases like tuberculosis and influenza-like illnesses. For response, how do we evolve our existing digital pandemic management system so that we can rapidly respond to new and emerging infectious diseases threats? I think there was a discussion earlier about if there will be another COVID-19 in the future. In my opinion, it's not a matter of if there will be another disease like COVID-19, it's when it will emerge. And that is the importance of preparedness. Let's draw what we can learn from COVID-19 and implement our preparedness plans so that we don't have to struggle like we have previously. So for response, there would need to be some kind of digital management system that represents it as well, just like COVID-19. And this system would have to be flexible, simple, and rapid, because we really don't know what disease X is in the future. We have to make it as generalized as possible. So how would we go about building on an automated communicable disease surveillance in Brunei? First of all, we need to know what is the current situation, which is landscape assessment, how we are doing things at the moment. And I can tell you that currently in Brunei, we are doing mostly by paper-based. And this is where we need to move away from. Then we engage the current users, the doctors, the healthcare staffs, the on-the-ground staffs, the health workers that are currently involved, and gather through a series of workshops what can be changed and how it should be done. Then we identify the diseases that are priorities of surveillance, i.e. diseases like tuberculosis and influenza-like illnesses. When we do have that information ready, and we do have that system ready, we must not forget to do field testing, whether it is relevant towards its purpose, that is fitness for purpose. And then we need to continue to monitor these systems because change is imminent. We need to make sure that it adapts for future changes as well. Just showing everyone a sneak peek of what we have in this pipeline about how we are going to look at other diseases currently for communicable diseases, for tuberculosis and influenza-like illnesses. So we're moving towards automation of our processes. And this is for every single diseases that is reportable to the Disease Control Division. Now, let's talk about the response bit. We've talked about the surveillance bit. Now we just quickly go talk about response. And recently, horizon scanning, monkeypox and other emerging diseases. There is an immediate need to prepare for the next disease. And it's only a matter of when, not if it will occur. And monkeypox is a disease which fits the criteria. And it's anticipated that it will require such a management similar to COVID-19. Now, that's why we created a digital management system for disease X, a disease that we have no idea about, and it has to be rapidly adaptable. But it will have features such as contact tracing, quarantine functions from COVID-19, and we have to distinguish it from other diseases. Let's say we have more than 2 in the future, COVID-19, disease X, and disease Y. We have to differentiate all of these. we have to flexibly set a quarantine period for all these as well. And then we need to capture information from our BRUHIMs, our electronic medical records, and link it up to BruHealth. This is just a quick sneak peek again about how we will go about in tackling the next pandemic. And if this is the front end for the patient side, for the public side, this will be the back end when we do contact tracing. And we can do contact tracing in a variety of ways, whether we want to do it self-reportedly by using Bluetooth proximity, Primer scan. We have all these available modalities to us. And also, we also can create a large event risk management, such as let's say MOS, just to monitor the amount of attendees. Now, a few take-home messages. COVID-19 highlights the importance of strengthening our preparedness and response capacities. And as countries scale down the acute pandemic response, we have COVID-19 tools that were already developed. And these COVID-19 tools need not be wasted. We can use these systems we develop to prepare for emerging threats. Digital tools and AI can support surveillance and response capacities as well. This is important when cases are increasingly exponentially to prevent public health capacity, so that public health capacity is not overwhelmed. This frees up our resources where it is most needed. And lastly, for digital systems to work well, we need to have data integration. That is crucial to ensure that our flow from healthcare provider to end user is not hindered. And with that, I end my talk, and thank you very much.